Hello, I'm your host, Dr. Roddy Raban, and on this week's episode of Plastic Surgery Uncensored, we're going to be taking a closer look at breast cancer and breast cancer reconstruction. I'm honored to have two of my dear colleagues, Dr. Jewell and Dr. Newman, who will help us navigate through everything you need to know about breast cancer reconstruction. Make sure to join us. Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Roddy Raban. I'm super excited today because we're going to be talking about a subject which is very near and dear to me, which is breast cancer and breast cancer awareness and breast cancer reconstruction. We're airing this obviously in the month of October, which is going to be Breast Cancer Awareness Month. And I'm really honored to have two really close and dear friends, but more importantly, experts in the field of breast cancer reconstruction. That is Dr. Lisa Jewell and Dr. Michael Newman. They specialize in breast cancer and breast cancer reconstruction. And while I used to do some of it, I hardly consider myself an expert. And so I feel grateful that you guys have joined us. So how you guys doing?
Great. Good to see you.
Nice to see you, Roddy.
All right. So, obviously, breast cancer reconstruction dovetails into cosmetics in that, well, we're dealing with the same anatomy, which is our breasts. And as well, I think one of the things that's really important is that, historically, reconstructive areas of plastic surgery, may it be breast reduction, may it be breast cancer reconstruction, cleft lip, palate, etc. Sometimes surgeons, there's two levels of expectation. One is to do the reconstruction, and then in modern day plastic surgery is really to get an outstanding aesthetic outcome, or an aesthetic outcome that makes patients happy. I think maybe a generation ago, partly because of the techniques that were available and partly just because patient demand, people were getting breast cancer reconstruction, but I don't necessarily know at the level that you guys are doing today, which is, wow, that looks really amazing. So why don't we start with you, Lisa, and tell me a little about your training and about you as a physician and why you've selected this area of medicine.
Well, I was fortunate enough to train at USC alongside you, Roddy, and completed my combined general and plastic surgery residency there. And then shortly after graduation, I had my first child, and again, had the opportunity to spend some time over at City of Hope with our mentor, Jim Anderson, who taught me the ins and outs and critical thinking that comes with being a microsurgeon. And he's just an all-around great guy, which I'm sure you would agree.
Yeah, I love that guy.
It took me a while, I think, to kind of find my footing and exactly how I wanted to balance my life and being a working mom, and eventually settled into a private practice in Torrance. Again, kind of lucky circumstances. About that time, Michael was coming out of his fellowship and looking for a job. And I think we both had similar expectations in what we wanted from our practice, and that we wanted to have a balance of breast reconstructive surgery or reconstructive surgery in general, and some cosmetic surgery in our practice. And the great thing about having a surgeon who employs both of those things in a practice is that they bring their knowledge and aesthetic sense from the cosmetic side into the reconstructive side, and vice versa. And so, to answer your question about the reason why I like this field, it's challenging. It's a challenge every day. Not only because I, am meeting women who are going through an incredibly stressful, sad, scary time of their life, but because the surgeries are technically demanding. And, Michael and I started, we were doing, 16-hour bilateral deep flaps, sometimes twice a week. And that takes a lot of camaraderie, and it takes a lot of patience, and it takes a lot of, dedication to the craft to do that. And that's really why I just love our practice.
You make some really great points, and I'm going to kind of highlight them as I hear them. One of them is the average person listening doesn't really kind of know where what begins within plastic surgery. So let's kind of just back up here for a moment, describe plastic surgery as a whole. So when we all trained, and of course I trained with Lisa and Mike at the same time in his own institution, people think plastic surgery is cosmetics. And the reality is that it is anything but cosmetics. Cosmetics is one of maybe 5 or 6 serious disciplines within plastic surgery. We have hand surgery, we have craniofacial, we have micro, or which sort of dovetails into breast reconstruction, and some other areas that people do. So when you decide to do high level of anything, you're going to want to focus your energy and drill it down and learn all the nuances related. So, it's not uncommon that people will pick or isolate certain areas to get really good at, because plastic surgery is complex. Breast cancer reconstruction is unique in that you guys are employing a lot of different techniques. And one thing that people don't really understand or know is, and we'll get into, because I'm going to ask you guys, Michael, I'm going to ask you to describe the various kinds, but it requires a lot of microsurgery, connecting small vessels under a microscope. So you can't just get up one day and be like, yeah, I'm going to do some breast cancer reconstruction and pop in a set of implants. You got to know, at least if you want to offer your patients the correct variety of options, you got to know how to do micro. So subspecializations or learning that skill set is what sort of differentiates individuals. And I know that both of you have great training. The second thing you stated, which is I think really interesting, is the balance of having some cosmesis, cosmetic surgery, doing a tummy tuck, doing, a breast aug, doing whatever it is that you also do, aside from the monotony of doing the same thing because you're well trained, is that it does allow you to have a sensitivity towards not just fixing the whole, but rather creating something beautiful in balance and in harmony. So Michael, what people want to, why don't we just talk about some really basics about breast cancer reconstruction? So a woman has, is diagnosed with breast cancer. She undergoes a removal of that breast cancer. It can be as small as a lumpectomy, a small area, or as much as the entire breast. Can you just walk us through some of the options or sort of the reconstructive ladder in terms of complexity of what people have available to them in terms of breast cancer reconstruction?
Yeah, so obviously stuff that you guys are very familiar with, but for the audience, we'll kind of go into it in a little bit of depth. But one thing to highlight, I think, is that breast reconstruction is covered by insurance. And so a lot of patients that come in ask, oh, well, I'm not happy with my breasts after my breast cancer removal, or I'm having breast cancer treatment. Is reconstruction covered? And I think it's important to address that legally, the federal government and the state governments require insurances that pay for mastectomy surgery or breast cancer surgery to also pay for reconstruction. So
great point. And we'll come back and circle back around the finances associated. That's a very important thing to discuss is the insurance component of it, because that wasn't always the case.
Right. Yeah, and so just kind of to superficially talk about the different types of things that can be done. So people that have a lumpectomy, as you said, especially in a patient with a larger breast or even a smaller breast, some tissue can be moved around to fill that hole or fill that defect and possibly lift the breast or make it smaller. So patients undergoing a lumpectomy can have some kind of reconstruction. And then the other group is people having a mastectomy. So if their entire breast is being removed, fortunately, in most cases these days, we're able to spare the nipple, but then the breast mound, that volume can be reconstructed either with an implant or some tissue from their own body, or sometimes a combination of both.
So let's go to the first scenario, which is a lumpectomy. So an individual, when gets a breast cancer, we won't get into quite the details of the cancer components, the various types and what they mean and the stages, et cetera. We'll leave that for another day. We want to really focus on the reconstruction and cosmetics. Mm-hmm. So in the best case scenario, and you have a small cancer or a small focus of cancer in your breast, they remove just that small segment, and they feel that based on the type of cancer and its location and the degree of it, it can safely be removed and you'll still be healthy. And that's called a lumpectomy, removing the lump. And then of course, you're going to be left with a defect, right? There'll be a hole there. And so that hole needs to, or could be, or should be brought back, reconstructed. I mean, you can just leave it, and of course that's acceptable, but in terms of ideal outcomes. So Lisa, what are the different, so you were filling in that defect, they had a lumpectomy. Scenario one is they have a really large breast, and for them, it's a small portion of it. What do you do in that instance?
Well, I think that's really kind of the critical decision-making that the breast surgeon, who is the oncologic surgeon who will remove the tumor, the patient and the plastic and reconstructive surgeon need to consider. We call lumpectomies nowadays breast conservation treatment or breast conservation therapy. But I think to be fair to the patient, you have to be very clear to them what the resulting conserved breast is going to look like. In a woman who has a very small breast and a very small tumor, breast conservation may be a good option for her. And the benefits to that would be a relatively, technically simple surgery, short recovery, relatively small scars, and she keeps her breast and her nipple sensation. The downside to breast conservation therapy, especially in a woman with a small breast, is that most women after breast conservation therapy will have radiation treatment. And radiation significantly changes the quality of the tissue. I mean, we call it the gift that keeps on giving because we use it to prevent local recurrence, to extend the life expectancy of women who are having lumpectomies or breast conservation treatment. But from a plastic surgery standpoint, when we talk about wound healing or when we talk about the ability of tissue to stretch and heal and sustain and recover from injury, radiation really continues over time and can have serious consequences later on in life. I think the worst case scenario in a woman who has breast conservation treatment or a lumpectomy and a small breast is that she has a contour deformity where the lumpectomy defect has scarred down after radiation, and the breast shrinks so that she has significant asymmetry in an already small breast. And that is an extremely difficult thing to treat. On the other end of the spectrum, if you have a woman with a really large breast, sometimes this is a blessing in disguise because she may have always thought about a breast reduction or some sort of improvement in how her breasts look, treating symptoms that go along with large breasts like neck pain, headaches, shoulder pain. And so when faced with the choice of having a lumpectomy or a mastectomy, this may be a good opportunity for her to have the lumpectomy and have the remaining breast tissue, if it is substantial, rearranged so that it looks like she just had a breast reduction or a breast lift. And of course, we would do surgery for symmetry on the other side. So oftentimes these women, despite having breast cancer, despite having a lumpectomy and radiation, will often have a more aesthetic breast than what they started with. And that's really satisfying and really, I think, our goal as reconstructive surgeons to produce something that looks better at the end than what we started with.
I think those are all very good points. And what you're basically alluding to is the idea a few things are important to take home. Number one, breast cancer reconstruction needs to be done as a team. You're not an isolated individual. So a patient doesn't just show up out of nowhere and says, hey, I have this cancer. They will have seen an oncologist, then they will see a surgical oncologist, and then they will see a reconstructive surgeon. So like certain areas in plastic surgery, it's a multidisciplinary approach. And when you undergo as a woman this procedure or you're diagnosed with this, who you work with as a team is crucial, because we all know, having done breast cancer reconstruction, if the person removing the cancer doesn't do a good job, AKA they're too aggressive, they make the leftover tissue very thin, etc., it makes the reconstructive component very challenging. So patients have to figure out their way into this process. And if they're lucky, they'll find an amazing team. And what I like about the way you guys run your practice is that you guys, as far as a team is concerned, you guys are a true team. And so you can't really create beautiful outcomes as an isolated great surgeon and then not have your oncologist. So people think that this plastic surgeon works in isolation, and that farthest from the truth. The second thing that you pointed out that I think is important to highlight is the removal in the instance of a lumpectomy, which patients initially think is the best option, right? I don't want a mastectomy. Totally understandable. But from a cosmetic standpoint, that may not necessarily be a bad outcome. And I think you made mention of the fact that it depends on how much is being removed relative to what you have left. And then something that you guys were talking about was where it's located. So if you remove something, a lump of a size of a golf ball from one area of the breast, it may not show. But if you remove it from another area of the breast, it may disfigure the entire breast. So those are all really, really crucial points to take into consideration. Michael, so that's step one. And then, we're going to chat a little bit out what the other options are, which are the more sophisticated options, not to suggest doing a breast reduction on a woman who had a lumpectomy and radiation is anything but sophisticated. But there is now the idea, okay, we're going to eventually get into the double mastectomy, Hollywood, everyone coming in asking for it in a minute. Don't worry, we'll get to Angelina Jolie effect of breast cancer reconstruction. But let's shift gears. And now, Michael, let's talk about, okay, so after you have seen this patient and the diagnosis was made and it becomes clear to you that if you do a lumpectomy or a breast conservation surgery, you're going to be left with an unattractive or cosmetically unacceptable outcome, then the next gear that you shift to is the possibility of doing a mastectomy or removing the entirety of breast gland. So can you explain this idea of nipple sparing and non-nipple sparing? Do we always remove the nipple? What do we do?
Yeah, so, looking at the history of mastectomy surgery, it used to be very aggressive where all the breast skin would be removed, the muscle would be removed, but fortunately that's all changed decades ago. And now we're able to preserve the muscle, preserve the breast skin. And really over the past 5 to 10 years, we're able to preserve the nipple as well in most cases. That's not true for everybody, but if the cancer is far from the nipple, then the nipple can be preserved. There are also situations sometimes aesthetically where the nipple might not be in the right place. Maybe the nipple is way too low in a very large breast. And so for those reasons, maybe we don't want to keep it. But in the majority of time, they can do a mastectomy, and like peeling an orange, they can peel the skin back, remove all the tissue underneath, and then we can do something to fill that space and then wrap it back up.
Right. So that's a great description, the peel the orange. I mean, essentially the idea is that there's a tumor, cancer, somewhere within the gland. And depending on where it is, will determine how much of the gland as well as the nipple you need to remove. I think you alluded to the back in the day, they referred to it as radical mastectomy, which is a perfect word for it because it was radical. You removed everything within sight. And now we're moving towards more advanced science-based preservation of anatomy. So we're going to take a quick break, and then when we come back, I want you to talk to me about the different options for filling in that envelope. So you've removed the breast tissue, you remove the tumor, let's do scenario 1 where you don't remove the nipple, and then scenario 2 where you have to remove the nipple because the cancer is close to it. And then you can tell me the different ways that you fill in that envelope because it's quite an art form. So you would definitely want to join us after the break. So this is Plastic Surgery Uncensored with Dr. Roddy Raban. Welcome back to Plastic Surgery Uncensored. So the second half of today's episode is about figuring out how to do breast cancer reconstruction in a way that is both functional and beautiful. So Michael, we were talking about you've done the mastectomy because you deemed it necessary, and that is you remove the entire gland. You've preserved the skin envelope, meaning the bag that holds the breast gland. And obviously, if you can, you will preserve the nipple if the cancer isn't too close to it. And so talk to me, I think let's work our way down. So let's do a nipple sparing reconstruction, meaning you have the skin and the nipple. What are your options in terms of filling that space in terms of reconstruction?
Yeah, so I think if we want to make it simple, I think we can. And really the choices come down to either using some kind of a device, some kind of implant, or using some of that patient's own tissue.
Correct. So implant reconstruction being using the same implant we would use for a breast augmentation, or autogenous or autologous tissue, meaning your own tissue. So tell me, Lisa, why don't you describe to me a little bit of how you do the implant reconstruction? So what people don't understand is when a patient gets a breast aug, it's nowhere near when they get a breast cancer reconstruction, even though we're both putting implants in, because what? There's a whole gland missing. There is no coverage over that implant. So you're talking about essentially an implant under skin, maybe, some muscle, but mostly skin. So tell me about how you approach an implant-based reconstruction. Do you put expanders? Do you do implants? And explain to me your thoughts.
So I do a two-stage implant reconstruction in patients, I would say 90% of the time. And that basically consists of placing a temporary implant to fill in the pocket. I will place it under the muscle if I know that the patient will eventually have an implant-based reconstruction. Sometimes we'll do a staged autologous tissue reconstruction where we use a tissue expander to preserve the skin, and then instead of filling it in with an implant, we would use their own tissue. The implant, typically when we put it under the muscle, we will use a sling of dermal graft at the bottom of the breast in order to provide more coverage of the tissue expander underneath the skin, so there isn't just skin on tissue expander or skin on implant. That graft can come from many different places. It can come from human donors, it can come from bovine donors, it can come from porcine donors. My preference lately has been to use a fetal bovine donor graft. And so we expand the patient. My technique is to expand the patient with air intraoperatively to make sure that there is no stress placed on the mastectomy skin flaps. Part of the reason I like the two-stage has to do with allowing the healing process to occur, not putting more stress on the skin or the nipple than we have to after a mastectomy. And then the nice thing about the tissue expanders is that they're adjustable. So in the office, the patient can say, hey, I love this size, let's leave it this size, or they can say, I want to be a little bit bigger, or I want to be a little bit smaller.
Okay. So let me interject a little bit on some of these things, because some of this stuff may be a little sophisticated. So the idea is that you remove the gland.
Yes.
Then you have two options to fill in that space. One is use an implant, some device, or the other use your own tissue. Down the implant device route, there are two options. One option is to go ahead, pick the final size, put the implant in, and do what's called a one-stage reconstruction, which I'm going to have Michael discuss. The other is a two-stage reconstruction, which is what you're referring to, is where you put an expander, which is a variable size implant, underneath the muscle, cover that implant up, and we'll talk about the bottom half, and then gradually and slowly expand it. And the reason you like that, and the reason why a lot of people use that, is it's a more conservative approach that puts a little less strain on all the things that are healing, because if it falls apart, you're in a big trouble.
Well, and there are two reasons to consider that. One is because we traumatize the skin during a mastectomy with instrumentation. We're trying to use small incisions. We're making incisions underneath the breast, so the reach to the very top of the breast is difficult. So we're really stressing the skin. And when we put in a final implant, and you know this from your practice, we want a bloodless, low inflammatory environment to prevent getting hardening of scar tissue around the implant. So in my practice, I feel that using a temporary device that allows me to, reduce the stress on the skin, to make a beautiful skin envelope, and then to come back later and replace that implant in a very clean, low inflammatory environment gives the best outcomes.
Yeah, and I think that's very good comment. And I think that every option has an advantage and disadvantage. And I do think that the overwhelming majority of conservative, and I hate to use the word conservative, but I will because it's my podcast, I can say whatever the hell I want. But conservative surgeons are going to advise their patients down a route that may seem longer, more tedious, more time-consuming for them and the patient, the surgeon and them. But the ultimate outcome is to reduce the probability of complications. And sometimes you need to take a longer route to get there. So you put in that expander, you gradually expand it, you allow the tissue to get some life back to it. You also get the variability of picking a size. And then ultimately you go back and swap that implant, that expander, for either an implant or some of your own tissue. The thing that you brought comment about, which we'll touch on, and I'm also going to have Michael talk about the single stage, is the top of the breast has muscle covering it. Awesome. Great. The bottom of the breast doesn't have muscle covering it. And in a regular breast augmentation, it's not a big issue because you have a bunch of breast tissue. But in a breast cancer reconstruction, the bottom half of the breast has skin over the implant. So aside from it looking terrible, it feels terrible, and it's a real precarious way. we're lucky because we're in the modern era of medicine, and we have so-called extracellular dermis, and they're all new names for them, but basically tissue from humans, pigs, cows that have been irradiated and that we use as scaffolding. So Michael, could you touch on that aspect in conjunction with, okay, some guys are out there going, well, I got a single stage reconstruction and I'm super happy. Not that one is better than the other, but let's at least have touched on the idea of not going down that route, although that is, in my opinion, the safer route.
Yeah, so as you mentioned, you kind of have these options of either a one-stage approach or a two-stage approach. The one-stage approach, of course, seems very enticing. You know, a lot of patients come in and they want surgery in one stage. They want to be one and done. And they look at their friends that had breast augmentation surgery for cosmetic purposes, and they say, well, they got implants and they only had to have one surgery and they recovered quickly and it wasn't a big deal. But what we have to do is educate patients to make them aware that, you know, breast cancer and breast reconstruction is a different game compared to breast cosmetic surgery, because there are just a lot of moving parts. There are a lot of variables. There's the tumor, the blood supply, the different layers of tissue, the support, and then the size. And so doing a one-stage reconstruction, I think, is great in some select patients when you have the right team and the right anatomy. But then for other patients, doing a two-stage approach with an expander to a second stage, then later with an implant, makes sense for most other patients. And just to touch on that dermal graft.
Yeah. So tell me what that is. And I mean, I'm putting a pig in my, what the hell, a pig in my, but I'm Jewish and I'm kosher. I can't have pig in my body. I mean,
yeah, that does come up, as you know. And so there are different parts of tissue that we can use. And as Lisa mentioned, they can come from different animals, but most commonly we use tissue. I think nationally, probably most commonly people use autologous tissue. So tissue from another human being, from a cadaver, all that tissue has been processed, whether it comes from a human or an animal. And we use that pretty much just to create some internal support, like an internal bra to hold the implant in place. Because usually the breast gland has some structure and support in it, but when you take out all the breast tissue, there's no more support. So we have to replace that support with something, and usually use some kind of cadaveric tissue. Now, as Lisa mentioned, many of us are putting the implants underneath the muscle, just like breast augmentation. But many other plastic surgeons, and me included, are transitioning somewhat towards putting the implant on top of the muscle. And so for that, we use a bigger sheet of that cadaveric tissue because we need more support. But either way, whether it's under the muscle or on top of the muscle, there's usually some element of that tissue for support that goes underneath the skin. And everybody gets freaked out. Oh, am I going to see this? Is it going to come out? Am I going to reject it? And the truth is, the body grows into it. It becomes part of your own tissue, and you never even know that it's there. It's just an internal bra.
Right. So I think this is a really important thing to touch on, and I'm going to expand just a moment here on it. So this extracellular matrix, this extraneous tissue, what is it and how does it work? First and foremost, for people who don't know anything about it, it's like a sheet of paper. It's not tissue in the sense that you think like you have a big glob of it, because the answer is like, why don't you make the whole breast out of it? It's not. It's thin, and it's a sheet-like material. Secondly, what it is that you take the skin of something, human, an animal, etc. Of course, they're dead. And you denude it or remove all of its cells. So the next question is, can I have a reaction to it? There's nothing really immunologic in it. It's just the sort of, they refer to it as a scaffolding, or like an architecture of collagen and whatnot. And then what it does is it serves as a support system from which your own tissues will grow, populate. And eventually, if you incorporate it, which we hope you do, you can cut it, it will bleed, and it's human and it's yours. So that's the sheet of paper that you're referring to. And of course, it's modern. That is one of the major advances of medicine. I use it in capsular contracture cases. You use it in breast cancer. You use it in abdominal hernias, etc. So it's really cool stuff. All right, we're going to make a segue here. It's a big segue, but we're going to do it, which is, in my opinion, the final grand poobah of a reconstruction, which is really where you guys come in, and in my opinion, where the advances are, which is, okay, I want my own tissue. I don't want an implant. I'm getting radiated. It's going to turn hard. I can see it. I can feel it, etc. So then what happens is that you decide to use your own tissue. So what do? Just suck up fat and pour it in there? No, you need to build the tissue from somewhere that is alive. So Lisa, tell me a little bit of the sort of, just for the basic audience, some of the levels of human tissue you can put in and the technique generally that you use to get it in there?
Yeah. Well, there are, the great thing about plastic surgery is that, those that came before us and hopefully, our generation are innovators and are never really satisfied with the status quo and are always looking for things to improve upon. And so, when looking at breast reconstruction, implants are an awesome option in most women, and it's the most commonly used breast reconstructive option. The downsides, and you mentioned this, they perform very poorly in patients who have had radiation, and they require maintenance. So even if a woman doesn't need radiation and she has a beautiful result, her body is going to change over time. Gravity is going to have its effect on the tissues. And the implant is a device that is, going to fail at some point in her lifetime. And so some patients don't want a device that they will have to, keep an eye on and have maintenance surgery on at some point in their future. So the next step in that process is using autologous tissue. And that means that it comes from another part of your body. It is an organ transplant. It is transplanting this organ or skin. It is transplanting fat. Sometimes it is transplanting muscle. And it ranges from what we call pedicled flaps, or flaps that carry their blood supply and it stays attached. And we move it from one part of the body to the other. So, one of the most common pedicled flaps we use in breast reconstruction is a latissimus flap. So that is the big muscle of your back. We can leave it attached to its blood supply under the armpit, make a nice little tunnel for it under the armpit, and drape this healthy, beautiful, robust muscle and a little bit of skin, if we need it, onto the breast. Now, it's a very thin muscle. It doesn't have a lot of tissue. So in that instance, we would need to add some volume, most likely in the form of a breast implant. So that's kind of a hybrid reconstruction. But the gold standard is using enough tissue from a part of a woman's body, most of the time it's the abdomen, that will bring enough volume that it makes the entire breast. Women who are affected by breast cancer are typically, after their childbearing years. Some of us who have had kids have a little extra, abdominal tissue that we would love to get rid of.
Dr. Jewel.
Oh yeah, unfortunately, it's true. And so this is, again, the silver lining. So we're trying to take, a really sad, scary time in a woman's life and give her the very best, most beautiful reconstruction that she can have. So when she's on the other end of it, she can say, man, this year was awful. It was the toughest of my life, but look at this brand new healthy body that I have to show for it. So getting back to the abdominal tissue, we can leave it attached to its blood supply, but the downside to that is we have to take one of those big, strong muscles in the front of the abdomen that give us our six-pack, called the rectus muscles. And the tissue, when we leave it attached and just kind of tunnel it up under the breast, is not as robust as if we detach the major blood vessels that supply that tissue in the groin, remove it completely from the body, and literally transplant that up into the chest. We have to connect the blood vessels so that the tissue stays alive, and that typically requires removing a little piece of rib and sewing very small blood vessels together, which requires a microscope. So we actually have a really cool piece of equipment that we use in the operating room that can magnify these vessels. And Michael and I sit there barely moving our hands, sewing these tiny little blood vessels together. But the advantage is this is healthy, robust, non-radiated tissue that is building a breast mound that doesn't require maintenance. Once that patient has had that reconstruction, that tissue is going to grow, change, age, get bigger, get smaller with her body. And so we consider this the gold standard for breast reconstruction.
Yeah. And I think that's very, you hit it on the head. I mean, there are different options for different people based on their needs, their desires, and their expectations. For some women, the idea of removing their abdominal fat pannus having it reconstruct a real breast, meaning real in that it's soft, it's malleable, and potentially getting a flatter abdomen is like a win-win. But it requires an extensive amount of training. It has a higher risk associated with it, some instances to failure. It requires a very skilled surgeon, etc. But that for them is a worthy trade-off. For others, it's not that relevant. They're the right candidate. They get an implant reconstruction, albeit expander and or immediate, and they feel satisfied. So what you're learning is that reconstructive surgery, as far as breast cancer, requires a surgeon and their patients to have a very healthy conversation regarding the options. And each of them is specific for that patient and the surgeon's skill set. What I like about you guys is that because you are trained to the nines, you can provide these patients every option. And as I'm sure you're going to recognize, unfortunately, some of the surgeons are either not trained with the microsurgical skills or are tired of that option, and as such do a disservice to their patients by not offering that or swaying patients towards a implant reconstruction, when in reality that may invariably not be their best option. So we find this problem in almost all areas of plastic surgery. I do a lot of body contouring. People come in, they should have got a body lift. They were told to get a tummy tuck. They hate the result. And the only reason they got a tummy tuck is because the surgeon doesn't do a body lift. So rather than saying, hey, you need a body lift, go find someone that does, they just gave them what they know how to do. And I think it's super, super great that you guys are able to offer whatever it is they need in that regard. I want to segue to probably one of the hottest topics in breast cancer reconstruction. And Michael, you're gonna hit this one. Is, you know, breast cancer, it always takes a celebrity to bring awareness to things. And, you know, we always know about things and there's amazing heroes out there, but until a celebrity talks about it, it sort of doesn't really get to the top of, you know, Yahoo News or, you know, Daily Mail. So Angelina Jolie is a well-known spokeswoman for breast cancer reconstruction, and the idea of double mastectomy. And my sister had a double mastectomy for breast cancer, not because of Angelina Jolie, but she actually needed it because she had cancer in both breasts. So Michael, what has that done, that being the Angelina Jolie situation, in favor and in pro breast cancer reconstruction? And what has it done that has been perhaps deleterious or damaging to breast cancer reconstruction in your vision?
Yeah, well, I think most of it's been very positive. I think number one, it's brought awareness, awareness of breast cancer and awareness about reconstruction. And then I think it's eliminated some of the stigma too. I think a lot of people feel self-conscious, they feel alone, they feel like they're the only ones going through this. But knowing that a beautiful, well-known celebrity has gone through that type of surgery and continued on to have a very successful and happy life, I think gives patients confidence and courage in the future. So I think it's really been mostly positive in those two aspects. And I think her going through that situation really has made it easier for people to take that step in their lives and make that choice. And I think it coincided with a lot of improvements in the techniques. And so, we talked about the different techniques of reconstruction, and we've had better implants, and we have this cadaveric skin that we can use for support, and microsurgery. Now we can preserve muscles and just take the fat in the skin. And so all those improvements have made reconstruction a lot better than it was, which I think has made more patients choose mastectomy and reconstruction as an option instead of lumpectomy.
I mean, I think that's really, really well said, which is, I think this is a very scary and lonely time for patients, even if they have loved ones. And I think having someone like Angelina Jolie be your spokeswoman in that it shows that you can persevere and not only just survive, but thrive is great. Having said that, have you not seen that patients who otherwise should have had a small reconstruction suddenly came and said, I want a double mastectomy, and perhaps due to fear and maybe even uninformed, have now decided that, no, I want a double mastectomy. I just want it, I want this. I don't want to have the risk. I don't want to deal with it. And maybe they were not statistically or medically indicated.
Yeah, I think there are some patients, I think, that come in with a lot of fear, and I'm not sure if that's related to Angelina Jolie necessarily, but just in general, I think they have a lot of fear about surveillance in the future. Will I get cancer again? Will I get cancer in the other breast? And I think our job as physicians is to reassure them about the statistics and tell them that it's unlikely that they'll have a recurrence. It's even less likely that they'll have cancer in their other breast. And so we can have a logical discussion about the numbers. And the oncologist is usually very good about that too, because they have a lot of those statistics at their fingertips. But I think there is a lot of fear, and I think sometimes people do overreact. And so I think, it's an important discussion that has to be had.
I think so too. Lisa, what was your experience with the sort of the, obviously if an individual, we'll just briefly mention it, we're not going to get too into it, but BRCA and the idea that you are predisposed, it was originally the idea was having a preemptive or what we refer to as a prophylactic mastectomy, meaning you have no breast cancer, but God, I don't want to get it, was for individuals who were genetically highly predisposed to getting it, which was, we have this genetic test called BRCA1 and 2. But I think my understanding was, and you would be able to address it better, is there was a high number of individuals who were not genetically highly predisposed, but from the fear and also breast cancer can give some incredible results, but seldom will it ever be better than your own breast. Mm-hmm. And so if you don't need it, you don't just run out and get it and say, okay, well, now I have bigger breasts. I wanted to nog anyways, and I don't have to worry about breast cancer. I think that we have to make sure that we understand the lack of knowledge or information there. What are your thoughts?
Well, Roddy, I would say that I really haven't had that experience. I haven't, had a patient who has no family history or hasn't had appropriate genetic counseling approach me and, be interested in a bilateral prophylactic mastectomy and reconstruction. And I really think that that's a testament to the team members that we have in our community. Patients will talk to their family practitioners or their OB-GYNs or their internists about their family history. They may get genetic testing, but the patients get good counseling before they come to us. And so they know ahead of time, listen, you may have a very strong family history, but you don't have any known genetic mutation. And I kind of emphasize known because I think every day we're learning that there are more genetic mutations besides the BRCA1 and 2 that can predispose a woman to have breast cancer. And so there's no medical reason or benefit to having a mastectomy. And so I think that because our colleagues are having those conversations with patients before they even come to us, we really haven't seen that. How I would counsel a woman who has a genetic predisposition would be, what is your anxiety level? Because maintenance is pretty good. I mean, not maintenance, but surveillance. Surveillance is pretty good. It's not perfect, but it's pretty good. So, but if your anxiety is going to be so heightened that it negatively affects your quality of life, then having a prophylactic mastectomy is probably the right decision. It's really kind of taking control and ownership of your health. And women have the right to do with their bodies whatever they choose. And so I would support her in that decision if that's what she wanted to do.
Okay, well, then there you have it. I think, anyone knows better than you guys because you're at the forefront, hearing, seeing, experiencing patients in this very crucial time. And I think we just keep going back to the same concept, which is education, team approach. Breast cancer is one of those unique areas where it's just not you and the internet, but you, your oncologist, your surgical oncologist, your plastic surgeon, even perhaps your OB. Everyone is together in this dialogue, and it's very tailored. And as you just described, there's a woman who may never even had breast cancer that gets a double mastectomy, and someone with breast cancer who's got large breasts and gets a tiny little lumpectomy and a breast reduction. I mean, those couldn't be further from each other, but yet somehow they fall under the same umbrella. So, we could talk for hours and hours and hours. I probably should have made this a 2-segment session. And I'm sure you guys are scratching your head going, why the hell are we doing this just in a short period of time? But I think we've covered some serious ground. At least I think for the time being, people are more educated than they were just 45 minutes ago. And absolutely, we're going to have another segment because I assure you there's going to be 1,000 questions regarding this very valuable concept and topic. And Lisa, I'm sorry, but we're going to have you back. You're going to have to doll yourself up one more time. Was this horrible? Was this awful? Was
Free,
you just
buddy.
nauseous the whole time?
Yeah, pretty much.
You did a great job, and the good news is that Michael made up for it.
Oh, he's the best. He's made for this stuff.
I will tell you, I'm jealous that you guys have each other. One of my only, not regrets, but wishes in my own private practice is the idea of having a colleague with whom I can work, with whom I can share, commiserate, and more importantly, share ideas. As an academic undertaking plastic surgery, it's really nice to have that. And I'm glad that you guys have found each other because you complement each other incredibly well. You guys are each other's yin and yang. And so kudos to you for surviving whatever it's been, 14 years together or whatever.
Yeah, about that. Mm-hmm.
All right, guys, we're going to wrap this up. And I appreciate you being here on this lovely Saturday. That wraps up another episode of Plastic Surgery Uncensored. Please join us next week because I'm sure whatever we're having is going to be just as interesting. All right, Maria?
Yes, sir. Got it.
I'm getting constant texts from Maria that you should have done it in 2 sessions.
You said you should have probably done this. And I go, yes, you should have. Like I said it.
Well, you guys,
you have to trust your producer.
I'm trying to navigate this here. You don't know what it's like.
Yes.
All right.
I do know what it's like. That's why I'm telling you.
You guys did awesome. I appreciate you being here, sharing, contributing. I hope that you got some of what you. Oh shit!
What?
Let me go back because I always want to tell them where they can be found.
Oh, okay.
Their practice name and things like that, so people can track.
I was going to tell you, but I wasn't. You wrapped it up so fast that I wasn't.
Well,
okay, we can butt it up. Just do the goodbye. Just.
It says 38 minutes, 42 minutes, 45. Like I feel like it's a
Oh, I have to tell you just so that you know.
I'm
okay.
aware.
Well, if you want, I don't do it, but okay, do the goodbye. Do it the goodbye again. Yeah. Okay, take second take of the goodbye. 5, 4. Oh, wait, let me get out of here. Ooh. 5, 4, 3, 2.
So that wraps up another episode of Plastic Surgery Uncensored. It was great having you both. For our listeners who want to be able to track you down and maybe come in, get some questions answered, whether that be for themselves or their family members, why don't you guys tell me where you guys can be found? Michael?
Yeah. We have an office in Torrance. South Bay Plastic Surgeons is the name, and the website is plasticsurgerysource.com.
South Bay, what?
Plastic Surgeons.
South Bay Plastic Surgeons. Don't go to Plastic. South Bay. Don't go to South Bay Plastic Surgery. You're going to go to somebody else's office. And what was the name of the website?
Plasticsurgerysource.com.
Plasticsurgerysource.com. And you can find Dr. Jewell on Instagram and Dr. Newman. But Dr. Newman, you're just going to be following him as he goes around the world surfing, and you're going to just be disappointed that your life isn't like his.
Might enjoy it.
All right, guys, thanks for joining me. Join us next week, as I'm sure whatever episode we're doing is going to be just as exciting and interesting. Yet another episode of Plastic Surgery Uncensored.